Imagine you're in hospital and your heart fails. You'd expect the crash team to rush in and make an attempt to save your life, wouldn't you? Making decisions about withholding or withdrawing life-prolonging medical treatment are among the most difficult issues facing both patients and the medical profession. Because of this, the British Medical Association has recently issued these guidelines to try and help doctors through this moral maze. The guidelines not only refer to withholding and withdrawing treatment from people for whom death is imminent, they also apply to people who have months and even years to live if treatment is provided. Although the guidelines say that doctors should consult patients and their families, the bottom line is that the decision on whether to treat or not is down to the doctor and the doctor alone. And there are fears that all too often decisions on whether to treat disabled people are being made on the basis of what the doctor believes is an acceptable quality of life. For example, the treatment or lack of it for disabled children frequently hits the headlines. Anne Hargaden is the mother of a disabled child who's recently died. She describes her experience of her son David being admitted to hospital with pneumonia.
The consultant approached us and said to us, would we consider withdrawing antibiotic treatment? My husband and I were stunned. We were just in a black hole of emotions that our son's life was considered so worthless, and that it was so easy for us to dispose of our son. And my husband has a name for it. He calls it disabled cleansing, which I think is a very good phrase to be used. You can be made to feel very guilty about keeping your child alive. You're often told it's a well-used phrase for parents of handicapped children that you're selfish to keep your child alive. Well, I don't consider it selfish at all. These are my two children. Now, which one am I a selfish mother to love, and which child am I a good mother to love? Because that's what they're saying.
But it's not just disabled children who can't speak out for themselves who are being denied treatment. Sue Maynard-Campbell is a successful disabled businesswoman.
I went into hospital with pneumonia, and at some point on about the second or third day that I was in there, the decision was made to put on my notes that I was not to be resuscitated. And the reason that I discovered after the event that was written on my records was because of my poor quality of life and because of my underlying medical condition. The doctor that made the decision had not spoken more than about half a dozen words to me. He had no idea who I was to be talking about my quality of life. I agree it's possible that going through the resuscitation process might not have been successful, but the important thing for me is that I should have been involved in that decision. That looks good. Cheers. Cheers.
One time, after we had been asked not to treat David when he was a baby, a different consultant was on duty one day, and she ticked us off as if we were 2-year-olds and told us to go away home and consider the quality of our child's life. David had a very good quality of life. He had a much better quality of life than some able-bodied children. He doesn't deserve to die because he's disabled.
Richard Light works for Disability Awareness in Action and has come across many cases like Sue and Anne's, and fears that the new guidelines will do little to help.
I think the BMA guidelines were ill-conceived, they are clumsy, certainly arrogant, and there's a great deal more that needs to be done in this area before any single body takes it upon itself to issue guidelines about the point at which it reserves the right to sign a death sentence.
As far as I'm concerned, the BMA guidelines are about money. They're serving their own best interests, and those interests are budget. They want to make themselves unaccountable to anyone when they decide to kill someone, and I don't think they should be above any law.
I took these fears to Michael Wilkes, chairman of the BMA's Ethics Committee. You do inevitably, though, get the situation where one doctor's view of what's beneficial is going to differ from another doctor's view.
Yes, I think that is quite true, but the variation in doctors' opinion will tend to be based on the doctor's own assessment of a sort of quality of life basis. And what we've tried to do in the sort of checklist for the assessments is to get as near a clinical assessment as we possibly can.
What the BMA representative is suggesting, in my view, is that it's fine, clinical assessments, all terribly scientific. The BMA guidelines themselves make it abundantly clear that there is a point in decisions like this where science is out through the window, and this is gut feeling. I think huge numbers of disabled people would be rightly cynical about the objectivity of the clinical assessment.
You'd be really fortunate if you found a doctor making a decision, a life and death decision about your treatment, who really understood the issues of quality of life for you as a disabled person. That's what really bothers me about the new guidelines, because it's down to the doctors. The last decision is for the doctor, and the doctors can make that on very, very sketchy knowledge and information.
To what extent are medical students taught about the social model of disability? Because disabled people do fear that they just see it as an illness rather than as something that can be lived with. Does that come into the training?
I think very poorly. I think ethics, the social aspects of medicine, the autonomy of the patient, the ability of patients to direct their own treatment, and far more importantly, or most importantly, the responsibility of doctors to listen and be guided by those wishes, I think is extremely badly taught, particularly in the more traditional medical schools.
Apart from giving a lot of power to doctors who might not be properly trained, there's also a fear that the guidelines are the start of a slippery slope towards euthanasia. Following the case of Tony Bland, who went into a coma after the Hillsborough disaster, the guidelines controversially include artificial nutrition and hydration as life-prolonging medical treatment.
The idea of being starved or dehydrated to death, I think for most of us would be fairly horrific. And it might be argued, not unreasonably, that an injection of the right sort of drug would be far kinder, far quicker. I don't think there's any question that once we start down that route, none of us can dictate where it's going to end.
Actually, is this the beginning of the BMA moving towards euthanasia?
No, I don't think so. We've said very clearly in the document that one of the primary underlying principles of our document is that when you make a decision about either withdrawing or withholding any sort of treatment, you may foresee the consequences of your decision, and the consequences of your decision may well be the earlier death of the patient, but you don't intend it. I think the moment a doctor has an intention in his mind to end life, that is clearly both criminal and unethical.
It's an intellectual sleight of hand to suggest that intent's the key, and we don't intend to kill somebody by withdrawing artificial hydration or feeding. Please.
The BMA guidelines say that decisions over withholding and withdrawing treatment should be carefully documented in the patient's notes and subject to review. The problem with this is that for some disabled people, this will be just too late to make a difference. If you've had any experiences of doctors making treatment decisions based on your quality of life, then call the phone lines on 0800 011 011.